Hello class, good day. I'm Ma'am Christina Henna and I'm going to discuss the concept of blood pressure and its assessment. This is the last concept I will be discussing because my next videos will be focused on the demonstration of taking the 4 vital signs. The topic I will be discussing today can be found in your Fundamentals of Nursing book by Potter and Perry, 10th edition in pages 503 to 510. So let's begin. So just like in taking of pulse, it is also very important to know the blood flow in our hearts when taking the blood pressure. So I encourage you to not forget your anatomy and physiology so you can get a good grasp of the physiology of blood pressure. So what is blood pressure? Blood pressure is the force exerted on the walls of an artery by the pulsing blood under pressure from the heart. Blood flows throughout the circulatory system because of the pressure changes. It moves from an area of high pressure to one of low pressure. Systemic or arterial BP, the BP in the system of arteries in the body, is a good indicator of cardiovascular health. The contraction of the heart forces the blood under high pressure into the aorta. So blood pressure is determined by the force and amount of blood pumped, and it is also determined by the size and flexibility of the arteries. The peak of maximum pressure when ejection occurs is the systolic pressure. When the ventricles relax, the blood remaining in the arteries exerts a minimum or diastolic pressure. So diastolic pressure is the minimal pressure exerted against the arterial walls at all times. So when we talk about arterial blood pressure, it is a measure of the pressure exerted by the blood as it flows through the arteries. So again, there are two blood pressure measures. One is the systolic pressure, and the second is the diastolic pressure. The standard unit for measuring blood pressure is millimeters of mercury, or the mmHg. The measurement indicates the height of which the blood pressure raises a column of mercury. So we need to record blood pressure with the systolic reading before the diastolic reading. For example, 120/80 millimeters of mercury is a desirable BP for healthy adults. The difference between systolic and diastolic pressure is the pulse pressure. So for example, for a blood pressure of 120/80, the pulse pressure is 40. So 20 to 40 is the normal pulse pressure. So let us now talk about the physiology of arterial blood pressure, or the determinants of blood pressure. Blood pressure reflects the interrelationship of cardiac output, peripheral vascular resistance, blood volume, blood viscosity, and artery elasticity. Your knowledge of these hemodynamic variables helps in the assessment of BP alterations. So again, these are your determinants for your blood pressure: the peripheral vascular resistance, cardiac output, elasticity, blood viscosity, and the blood volume. Let's first talk about the cardiac output, but let us review some definitions we learned when we talked about the physiology of pulse, as it is also the same with blood pressure. So when we talk about the quantity of blood forced out of the left ventricle with each contraction, it is called the stroke volume. A stroke volume is the amount of blood ejected by the ventricle per contraction. So it is influenced by the amount of blood in the heart before it contracts. Again, cardiac output is heart rate times stroke volume. The blood pressure depends on the cardiac output. When volume increases in an enclosed space, such as a blood vessel, the pressure in that space rises. Thus, as cardiac output increases, more blood is pumped against arterial walls, causing the BP to rise. Cardiac output increases as a result of an increase in heart rate, greater heart muscle contractility, or an increase in blood volume. Changes in heart rate occurs faster than changes in heart muscle contractility or blood volume. A rapid or significant increase in heart rate decreases the filling time of the heart. As a result, the BP decreases. The next determinant is your peripheral resistance. The blood pressure depends on peripheral vascular resistance. Blood circulates through a network of arteries, arterioles, capillaries, venules, and veins. Arteries and arterioles are surrounded by smooth muscles that contracts or relaxes to change the size of the lumen. The size of arteries and arterioles changes to adjust blood flow to the needs of local tissues. For example, when a major organ needs more blood, the peripheral arteries constrict, decreasing their supply of blood. More blood becomes available to the major organ because of the resistance change in the periphery. Normally, arteries and arterioles remain partially constricted to maintain a constant flow of blood. Peripheral vascular resistance is the resistance to blood flow determined by the tone of vascular musculature and the diameter of blood vessels. The smaller the lumen of a vessel, the greater is the peripheral vascular resistance to blood flow. As resistance rises, arterial BP rises. As vessels dilate and resistance falls, BP drops. The next determinant is your blood volume. The volume of blood circulating within the vascular system affects blood pressure. Most adults have a circulating blood volume of 5 liters. Normally, the blood volume remains constant. However, an increase in volume exerts more pressure against arterial walls. For example, the rapid, uncontrolled infusion of IV fluids elevates blood pressure. When a person's circulating blood volume falls, as in the case of hemorrhage or dehydration, the blood pressure falls. Another determinant would be your blood viscosity. The thickness or viscosity of blood affects the ease with which blood flows through small vessels. The hematocrit, or percentage of red blood cells in the blood, determines blood viscosity. When the hematocrit rises and blood flows slow, arterial BP increases. The heart contracts more forcefully to move the viscous blood through the circulatory system. The last determinant would be your elasticity. Normally, the walls of an artery are elastic and easily distensible. As pressure within the arteries increases, the diameter of vessel walls increases to accommodate the pressure change. Arterial distensibility prevents wide fluctuations in blood pressure. However, in certain diseases such as arteriosclerosis, the vessel walls lose their elasticity and are replaced by fibrous tissues that cannot stretch well. Reduced elasticity results in greater resistance to blood flow. As a result, when the left ventricle ejects its stroke volume, the vessel no longer yields to pressure. Instead, a given volume of blood is forced through the rigid arterial walls, and the systemic pressure rises. Systolic pressure is more significantly elevated than diastolic pressure as a result of reduced arterial elasticity. Each hemodynamic factor significantly affects the other. For example, as arterial elasticity declines, peripheral vascular resistance increases. The complex control of the cardiovascular system normally prevents any single factor from permanently changing the blood pressure. For example, if the blood volume falls, the body compensates with an increased vascular resistance. So again, let's look at the factors that increase blood pressure. So one, increased cardiac output. Another would be increased peripheral vascular resistance, increased blood volume, increased blood viscosity. And the factors that decrease blood pressure would be decreased cardiac output, decreased peripheral vascular resistance, decreased blood volume, and decreased blood viscosity. So let us talk about factors affecting blood pressure. Blood pressure is not constant. Many factors continually influence it. One measurement cannot adequately reflect a patient's usual blood pressure. Even under the best conditions, it changes from heartbeat to heartbeat. Blood pressure trends, not individual measurements, guide nursing interventions. Understanding these factors ensures a more accurate interpretation of blood pressure readings. So what are these factors? We've got age, stress, race or ethnicity, gender, daily variations, medications, activity and weight, and smoking. So let's now talk about age. Normal blood pressure levels vary throughout life. Blood pressure increases during childhood. Evaluate the level of a child's or adolescent's blood pressure with respect to body size and age. An infant's blood pressure ranges from 65 to 115 over 42 to 180 milliliters of mercury. The normal blood pressure for a 7-year-old is 87 to 117 over 48 to 64 millimeters of mercury. Larger children, heavier and taller, have higher blood pressures than smaller children of the same age. During adolescence, BP continues to vary according to body size. An adult's blood pressure tends to rise with advancing age. The optimal blood pressure for a healthy middle-aged adult is less than 120 over 80. Values of 120 to 139 systolic and 80 to 89 diastolic are considered pre-hypertension. Older adults often have a rise in systolic pressure related to decreased vessel elasticity. However, blood pressure greater than 140/90 is defined as hypertension and increases the risk of hypertension-related illness. Another factor is stress. Anxiety, fear, pain, and emotional stress result in sympathetic stimulation, which increases heart rate, cardiac output, and vascular resistance. The effect of sympathetic stimulation increases blood pressure. Anxiety raises blood pressure as much as 30 millimeters of mercury. Next is race or ethnicity. The incidence of hypertension or high blood pressure is higher in African Americans than in European Americans. African Americans tend to develop more severe hypertension at an early age and have twice the risk for complications such as stroke and heart attack. Genetics and environmental factors are often contributing factors. Hypertension-related deaths are also higher among African Americans. Next is gender. There is no clinically significant difference in blood pressure levels between boys and girls. After puberty, males tend to have a higher blood pressure readings. After menopause, women tend to have higher blood pressure levels than men of similar age. Then we have your daily variations. Blood pressure varies throughout the day, with lower blood pressure during sleep between midnight and 3 a.m. Between 3 a.m. and 6 a.m., there is a slow and steady rise in blood pressure. When a patient awakens, there is an early morning surge. It is the highest during the day between 10 to 6 p.m. No two people have the same pattern or degree of variation. Then we have your medications. Some medications directly or indirectly affect blood pressure. Before blood pressure assessment, ask whether the patient is receiving antihypertensive, diuretic, or other cardiac medications which lower blood pressure. Another class of medication affecting blood pressure is your opioid analgesics, which can also lower your blood pressure. Vasoconstrictors and an excess volume of intravenous fluids can increase it. Another factor would be your activity. A period of exercise can reduce blood pressure for several hours afterwards. An increase in oxygen demand by the body during activity increases blood pressure. Inadequate exercise frequently contributes to weight gain, and obesity is a factor in the development of hypertension. Again, talking about weight, pressure is generally higher in some overweight and obese people than in people of normal weight. Both childhood and adult obesity predispose to hypertension. So the last factor that we'll be talking about that influence blood pressure is smoking. So smoking results in vasoconstriction, a narrowing of blood vessels. BP rises when a person smokes and returns to baseline about 15 minutes after stopping smoking. So there are two variations in blood pressure. So when we talk about hypertension, it is increased blood pressure, and the decrease of blood pressure is called hypotension. An abnormally high blood pressure over 140 mmHg systolic and a 90 millimeters of mercury diastolic confirmed during a minimum of 2 consecutive visits by a client. So let's now talk more about hypertension. The most common alteration in blood pressure is hypertension. Hypertension is often asymptomatic. Pre-hypertension is diagnosed in adults when an average of 2 or more readings on or at least 2 subsequent visits is between 120 and 139 systolic and 80 to 89 diastolic. Diastolic readings greater than 90 millimeters of mercury and systolic readings greater than 140 define hypertension. Hypertension is associated with thickening and loss of elasticity in the arterial walls. Peripheral vascular resistance increases within a thick and inelastic vessels. The heart continually pumps against greater resistance. As a result, blood flow to vital organs such as heart, brain, and kidney decreases. So people with family history of hypertension are at significant risk. Modifiable risk factors include obesity, cigarette smoking, heavy alcohol consumption, and high sodium or salt intake. Sedentary lifestyle and continued exposure to stress are also linked to hypertension. The incidence of hypertension is greater in patients with diabetes, older adults, and African Americans. It is a major factor underlying deaths from stroke and is a contributing factor to myocardial infarction or heart attacks. When patients are diagnosed with hypertension, educate them about blood pressure values, long-term follow-up care and therapy, and the usual lack of symptoms, the fact that it may not be felt, the ability of therapy to control but not cure it, and a consistently followed treatment plan that ensures a relatively normal lifestyle. So here's a table about the classification of blood pressure for adults ages 18 and older. So we've got the categories: the normal, the pre-hypertension, stage 1 hypertension, and the stage 2 hypertension. So if you look at the normal, it's below 120 and the diastolic would be below 80. But when we go to the pre-hypertension, it's above, it's in 120 to 139 and our diastolic is 80 to 89. Stage 1 hypertension, it's equal to or greater than 140 and the diastolic is equal to or greater than 90. And the stage 2 hypertension is equal to and greater than 160 and the diastolic as well is equal to and greater than 90. So the other variation for blood pressure is hypotension. Hypotension is present when the systolic BP falls to 90 or below. Although some adults have a low BP normally, for most people, low BP is an abnormal finding associated with illness. Hypotension occurs because of the dilation of the arteries in the vascular bed, the loss of a substantial amount of blood volume, example through hemorrhage, or the failure of the heart muscles to pump adequately, example during myocardial infarction. Hypotension associated with pallor, skin mottling, clamminess, confusion, increased heart rate, or decreased urine output is life-threatening and is reported to a healthcare provider immediately. So let's now talk about orthostatic hypotension, also referred to as a postural hypotension. Occurs when a normotensive person develops symptoms and a drop in systolic pressure by at least 20 millimeters of mercury or a drop in diastolic pressure by at least 20 millimeters of mercury within 3 minutes of rising to an upright position. So in a healthy individual, changes from a lying to sitting to standing position, the peripheral blood vessels in the legs constrict. When standing, the lower extremity vessels constrict, preventing the pooling of blood in the legs caused by gravity. Thus, an individual normally does not feel any symptoms when standing. In contrast, when patients have a decreased blood volume, their blood vessels are already constricted. When a patient with volume depletion stands, there is a significant drop in blood pressure, with an increase in heart rate to compensate for the drop in the cardiac output. Patients who are dehydrated, anemic, or have experienced prolonged bed rest or recent blood loss are at risk for orthostatic hypotension, particularly in the morning. Some medications cause orthostatic hypotension as well if misused, especially in older adults or young patients. Always measure blood pressure before administering such medications. Assess for orthostatic hypotension during measurements of vital signs by obtaining blood pressure and pulse in sequence with the patient supine, sitting, and standing. Obtain BP readings within 3 minutes after the patient changes position. In most cases, orthostatic hypotension is detected within a minute of standing. If it occurs, help the patient to a lying position and notify the healthcare provider or nurse in charge. While obtaining orthostatic measurements, observe for other symptoms of hypotension such as fainting, weakness, blurred vision, or lightheadedness. Postural hypotension is a risk factor for falls, especially among elderly patients with hypertension. When recording orthostatic BP measurements, record the patient's position in addition to the BP measurement. Example, 140/80 supine, 132/72 sitting, 108/60 standing. The skill of postural hypotension measurements requires critical thinking and ongoing nursing judgment when determining a patient's response to repositioning, so do not delegate this procedure. So moving forward, we will now be talking about assessing blood pressure or the measurement of blood pressure. Arterial BP measurements are obtained either directly, invasively, or indirectly, non-invasively. The direct method requires the insertion of a thin catheter into an artery. Tubing connects the catheter with electronic hemodynamic monitoring equipment. The monitor displays a constant arterial pressure waveform and reading. Because of the risk of sudden blood loss from an artery, invasive BP monitoring is used only in intensive care settings. The common indirect method requires a sphygmomanometer and a stethoscope. Auscultation or palpation with auscultation is the most widely used technique. So the blood pressure equipment that we're going to use is the sphygmomanometer and the stethoscope. Before assessing the blood pressure, make sure that you are comfortable using the sphygmo and the stethoscope. A sphygmomanometer includes a pressure manometer, an occlusive cuff that encloses an inflatable rubber bladder, and a pressure bulb with a release valve that inflates the bladder. The aneroid manometer has a glass-enclosed circular gauge containing a needle that registers millimeter calibrations. Before using the aneroid model, make sure that the needle points to 0 and the manometer is correctly calibrated. Aneroid sphygmo requires biomedical calibrations every 6 months to verify accuracy. So this is just a picture of the placement of blood pressure cuff. The occlusive cuff comes in different sizes. The size selected is proportional to the circumference of the limb being assessed. Ideally, the width of the cuff is 40% of the circumference of the midpoint of the limb in which the cuff is used to measure the blood pressure. So this is just a picture to show that if you're using the right cuff. To find out if you're using the right size cuff, compare the length of the bladder inside the cuff with the circumference of the patient's arm. If the bladder is at 80% of the circumference of his arm, your reading should be accurate. The inflatable bladder contained in the occlusive cuff encircles at least 80% of the upper arm of an adult and the entire arm of a child. So place the lower edge of the cuff above the antecubital fossa, allowing room for positioning the stethoscope bell or diaphragm. Many adults require a large adult cuff. An improperly fitting cuff causes inaccurate BP measurements. So talking more about the bladder is covered with cloth and has 2 tubes attached to it. One tube connects to a rubber bulb that inflates the bladder. When turned counterclockwise, a small valve in the side of this bulb releases the air in the bladder. When the bulb is tightened, air pumped into the bladder remains there. The other tube is attached to a sphygmomanometer, which indicates the pressure of the air within the bladder. The bladder must be in the correct width and length for the clients. The length of the bladder affects the accuracy of measurement. If the bladder is too narrow, the blood pressure reading will be erroneously elevated. If it's too wide, the reading will be erroneously low. The arm circumference, not the age of the client, should always be used to determine the bladder size. So this is just a picture of the aneroid sphygmomanometer. The aneroid is a calibrated dial with a needle that points to the calibrations. So there are 2 blood pressure sides that we can use as sphygmo and the stethoscope. So one would be the arm, and we use the brachial artery in that side, and the other is a thigh. So if the blood pressure cannot be measured in either arms, then we can use the thigh. So dressing, cast IV catheters or intravenous fluids or arteriovenous fistulas or shunts make the upper extremities inaccessible for BP measurements. You then need to obtain the BP in a lower extremity. So comparing upper extremity blood pressure with that in the legs is also necessary for patients with certain cardiac and BP abnormalities. The popliteal artery, it's palpable behind the knee in the popliteal space, is the site for auscultation. The cuff needs to be wide and long enough to allow the larger girth of the thigh. Placing the patient in a prone position is best. If such a position is impossible, ask the patient to flex the knee slightly for easier access to the artery. So lower extremity blood pressure, this procedure is identical to brachial artery auscultation. So systolic pressure in the legs is usually higher by 10 to 40 millimeters of mercury than in the brachial artery, but the diastolic pressure is the same. So blood pressure is not measured on client's arm or thigh in the following situations. So the shoulder, arm, or hand, or the hip or knee or ankle is injured or diseased. A cast or bulky bandage is on any part of the limb. The client has had a removal of axilla lymph nodes on the side. We don't want to use or get the blood pressure on that side because it can lead to secondary lymphedema in the extremities. So if the client has intravenous infusion in that limb, avoid that site as well because you might blow the IV site. If the client has an arteriovenous fistula for renal dialysis in that limb, avoid that site as well when taking the blood pressure because you might damage the fistula. So there are two non-invasive indirect methods of blood pressure measurement. One is auscultatory method and the other is palpatory method. The best environment for blood pressure measurement by auscultation is a quiet room at a comfortable temperature. Although the patient may lie or stand, sitting is the preferred position. In most cases, BP readings obtained with the patient in the supine, sitting, and standing position are similar. The patient's position during routine BP determination needs to be the same during each measurement to permit a meaningful comparison of values. Before obtaining the patient's blood pressure, attempt to control factors responsible for artificially high readings such as pain, anxiety, or exertion. The patient's perception that the physical or interpersonal environment is stressful affects the BP measurements. During the initial assessment, obtain and record the BP in both arms. Normally, there's a difference of 5 to 10 millimeters of mercury between the arms. In subsequent assessment, measure the BP in the arm with the higher pressure. Pressure difference greater than 10 indicates vascular problems and are reported to the healthcare provider or nurse in charge. Ask the patient to state his or her usual blood pressure. If the patient does not know, inform him or her after measuring and recording it. This is a good opportunity to educate the patient about optimal values of blood pressure, risk factors for developing hypertension, and dangers of hypertension. Indirect measurement of arterial BP works on a basic principle of pressure. Blood flows freely through an artery until an uninflated cuff applies pressure to tissue and causes the artery to collapse. After the release of the cuff pressure, the point at which blood flows returns and the sound appears through auscultation is the systolic pressure. In 1905, Korotkov, a Russian surgeon, first described the sounds heard over an artery distal to the BP cuff when the cuff was deflated. So the first sound is a clear rhythmical tapping corresponding to the pulse rate that gradually increases in intensity. Onset of the sound corresponds to the systolic pressure. A blowing or swishing sound occurs as the cuff continues to deflate, resulting in the second sound. As the artery distends, there is turbulence in blood flow. The third sound is a crispier and more intense tapping. The fourth sound becomes a muffled and low-pitched as the cuff is further deflated. At this point, the cuff pressure has fallen below the pressure within the vessel walls. This sound is the diastolic pressure in infants and children. The fifth sound marks the disappearance of sound. In adolescents and adults, the fifth sound corresponds with the diastolic pressure. So in some patients, the sounds are clear and distinct. In others, only the beginning and ending sounds are clear. So the American Heart Association recommends recording two numbers for a BP measurement. The point on the manometer when you hear the first sound for systolic and the point on the manometer when you hear the fifth sound for diastolic. So some institutions recommend recording the point when you hear the fourth sound as well, especially for patients with hypertension. So BP assessment results in many medical decision and nursing interventions. So obtaining an accurate measurement is essential. So let's delve deeper on the Korotkov sounds. So the phase 1, the pressure level at which the first faint, clear tapping or thumping sounds are heard. These sound gradually becomes more intense. To ensure that they are not extraneous sounds, the nurse should identify at least two consecutive tapping sounds. The first tapping sound heard during deflation of the cuff is the systolic blood pressure. So if it's here from silence going to the tapping sound, that would be your systolic pressure. So phase 2 is the period during deflation when the sound have a muffled, whooshing or swishing quality. Phase 3 is a period during which the blood flows freely through an increasing open artery, and the sounds become crispier and more intense, and again assume a thumping quality but softer than in phase 1. In phase 4, the time when the sound becomes muffled and have a soft blowing quality, and in phase 5, the pressure level when the last sound is heard. This is followed by a period of silence. The pressure at which the last sound is heard is the diastolic blood pressure in adults. So let's talk about the assessment in children. All children 3 years of age through adolescent need to have blood pressure checked at least annually. BP in children changes with growth and development. Help parents understand the importance of this routine screening to detect children who are at risk of hypertension. So the measurement of blood pressure in infants and children is difficult for several reasons. First, there's a different arm size requires careful and appropriate cuff size selection. So do not choose a cuff on the basis of the name of the cuff, like an infant cuff is often too small for some infants. Readings are difficult to obtain in restless and anxious infants and children. Allow at least 15 minutes for children to recover from recent activities and become less apprehensive. The child's cooperation is increased when you or the parent have prepared him or her for the unusual sensation of the BP cuff. Most children understand the analogy of a tight hug on the arm. And the third, placing the stethoscope too firmly on the antecubital fossa causes errors in auscultation. Sounds are difficult to hear in children because of low frequency and amplitude. A pediatric stethoscope bell is often helpful. So, when you are unable to auscultate sound because of a weakened arterial pulse, you can use an ultrasonic stethoscope. This stethoscope allows you to hear a low-frequency systolic sound. You frequently use this device when measuring the BP of infants and children and low BP in adults. So there's actually a lot of variations for the ultrasonic stethoscope. So this is just one picture of them. So moving forward, another method for obtaining indirect blood pressure measurement is through palpatory method or palpation. So indirect measurement of blood pressure by palpation is useful for patients whose arterial pulsations are too weak to create sounds. Severe blood loss and decreased heart contractility are examples of conditions that results in blood pressure too low to auscultate accurately. In these cases, you can assess the systolic BP by palpation. The diastolic BP is difficult to determine by palpation, so when using the palpation technique, record the systolic value and how you measured it. Example, the systolic value is 90 and there's no diastolic, and you just write palpated and supine. You can use the palpation technique along with auscultation. In some patients with hypertension, the sounds usually heard over the brachial artery when the cuff pressure is high disappears as pressure is reduced and then reappear at a lower level. This temporary disappearance of sound is the auscultatory gap. It typically occurs between the first and second sounds. The gap in sounds covers a range of 40 millimeters of mercury and thus causes an underestimation of systolic pressure or overestimation of diastolic pressure. The examiner needs to be certain to inflate the cuff high enough to hear the true systolic pressure before the auscultatory gap. So palpation of the radial artery helps determine how high to inflate the cuff. The examiner inflates the cuff 30 millimeters of mercury above the pressure at which the radial pulse was palpated. So if you notice during your blood pressure taking an auscultatory gap in your patient, so please tell the nurse in charge and write it in your nurse's notes. So moving on, we will talk about electronic blood pressure devices. So many different styles of electronic BP machines are available to determine the blood pressure automatically. Electronic BP machines rely on an electronic sensor to detect the vibrations caused by the rush of blood through an artery. Use electronic devices when frequent blood pressure assessment is necessary, such as in patients who are critically ill or unstable, during or after invasive procedures, or when therapies require frequent monitoring. Example, giving of blood pressure medications. So the advantages of automatic devices are the ease of use and efficiency when repeated or frequent measurements are indicated. So the ability to use a stethoscope is not necessary. However, automatic devices are not recommended for hypertensive patients, patients with irregular heart rates, or those who have experienced trauma. Most electronic BP devices are unable to process sounds of vibrations of low BP. The range of device sophistication also makes BP measurement comparison difficult. So talking about self-measurement of blood pressure, improved technology as electronic monitoring devices allows individuals to measure their own blood pressures in their home with a push of a button. The electronic devices are easier to manipulate but require frequent recalibration more than once a year because of their sensitivity. Improper cuff placement or movement of the arm causes electronic devices to give incorrect readings. So stationary automatic BP devices are often found in public places such as grocery stores, fitness clubs, airports, or work sites. Users simply rest their arms within the inflatable cuff of the machine, which contains a pressure sensor. A visual display tells users their BP within 60 to 90 seconds. The reliability of the stationary machine is limited. Self-measurement of blood pressure has several benefits. Sometimes elevated BP is detected in people previously unaware of a problem. People with pre-hypertension provide information about the pattern of BP values to their healthcare provider. Patients with hypertension benefit from participating actively in their treatment through self-monitoring, which helps adherence with treatment. The disadvantage of self-measurement includes improper use of the device and the risk of inaccurate readings. Some patients are needlessly alarmed with one elevated reading. Some patients with hypertension become overly conscious of their BP and inappropriately self-adjust their medications. So as a nurse or a student nurse, advise patients of possible inaccuracies in the BP devices. Help them understand the meaning and the implications of readings and teach them proper measurement techniques. Encourage them to record the date of their BP readings to assess BP over time and share findings with their healthcare provider. So what are the common errors in assessing blood pressure? Number 1, there's a haste on the part of the nurse. Number 2, subconscious bias. A nurse may be influenced by the client's previous blood pressure measurements or diagnosis and hear a value consonant with the practitioner's expectations. And then we have others. So these are the other common errors. When the bladder cuff is too narrow, there's a false high reading. So when the bladder cuff is too wide, there's also a false low reading. When the arm is unsupported, there's a false high reading. Insufficient rest before the assessment, there's a false high reading. Repeating assessment too quickly, also false high systolic or false low diastolic readings. Cuff wrapped too loosely or unevenly, false high reading. Deflating cuff too quickly, false low systolic and false high diastolic readings. Other errors: deflating cuff too slowly, the effect would be false high diastolic readings. Failure to use the same arm consistently, it's inconsistent measurements. Arm above level of the heart, there's false low readings. Assessing immediately after a meal or while client smokes or has pain, it causes false high reading. Failure to identify the auscultatory gap, false low systolic pressure and false low diastolic reading. And arm below heart level, it's false high reading. So the other errors is when the stethoscope is applied too firmly against the antecubital fossa, it causes false low diastolic reading. And when the stethoscope that fits poorly or impairment of the examiner's hearing causing sounds to be muffled, so it causes false low systolic and false high diastolic reading. So yay, that ends our discussion with the concept of blood pressure and taking of blood pressure. I know that's a lot of information to swallow and too little time to digest it fully, but if you have any questions or concerns, again, please write it down and ask your clinical instructor those questions during your synchronous class. So I won't bid you goodbye because I still have one video left to do, and that's demonstrating how to take your vital signs, which you will return demonstrate to us in the coming fortnight. So thank you and God bless you all.